and Mendeszoon out of Ohio and Dr. Anderson out of Utah. I'll have them share their experience. They've both been using the product now for coming up on about 2 years, plus or minus, so they'll be able to share their own personal experience and give you some of their own flavor of evidence-based medicine. So with that, let me begin. And again, what we wanted to talk about today is some of the utility of the Tenex Health TX system for foot and ankle conditions. We use this slide to kind of frame our technology, and it kind of sits in between what today has been the standard of care for chronic tendinosis. Let me get rid of this. Today, as many of you know, the conservative treatment works actually relatively well. If you look at some of the clinical data, there's about a 70 to 75% success rate that conservative treatments are very effective when you look at Achilles tendinoses or certainly plantar fasciitis. And I think there's a healthy debate of the benefit of cortisone now, and certainly a very rigorous debate about the benefit of multiple injections of cortisone being really deleterious for this condition. And then on the other side, on the right side of the spectrum, you have either an arthroscopic and an open approach. And the goal there, again, is to cut and remove the damaged tissue, which is the pain generator. And then what it has in terms of collateral issues is it's a relatively long recovery time. So when we developed our technology, we really looked at it as what's the unmet need, and it's the spot in the middle. And it's kind of captured in the green box in the bottom, is that we're really looking at providing and affording a treatment for those patients that have failed conservative measures, that have chronic conditions of lasting more than 3 months. And we certainly wanted to have the effect of surgery, but without the invasiveness of an injection. So that's where the TX system comes in. It's a needle-based approach, and it allows the physician to treat that very focused tissue as they would surgery, but without the need of surgery and under local anesthesia. It also has a definitive treatment. It's a single treatment, very much like the surgical approach. The next slide kind of gives you a snapshot of the patients that we have treated. We've launched the product in the U.S. In the beginning of 2012, and we've touched 30,000 patients successfully. And this is, again, a distribution of the areas that we've treated. Well over 50% of them are foot and ankle. And this, roughly describes the incidence, and certainly from a pathobiology standpoint of where you see the chronic conditions, whether it's in the shoulder, all the way down to the foot and ankle. And I will just remark that on the Achilles, we've treated both insertional Achilles tendinoses as well as mid-substance. The next slide here talks a little bit about our instrumentation. It's really divided into a console, and the capital piece of equipment has embedded within it the circuitry. And the circuitry is in the name of a frequency of ultrasound that is precise in cutting and removing necrotic, degenerated tendon tissue or plantar fascia. Well, let me just start there. So we're talking about the console and our instrument. The console has, as I said, the instrumentation and the frequency that delivers the energy to break down the tissue. It has a number of safety features, and it uses the advantage of diseased tissue. Has a different density than healthy tissue, which is elastic. The instrument on the right side, that's the disposable instrument. That's single use. That's what's delivered percutaneously. And then the tissue, as well as the irrigated saline to keep the needle cool, that's collected in the bag. The next slide talks a little bit more about the science. The needle goes back and forth in a longitudinal motion. It's microscopic, but it moves at a frequency in excess of 20,000 times a second. And we have a proprietary frequency that breaks down just that necrotic tissue. As I said, degenerated tissue, which is collagen-based, has a density which is discriminate from healthy tissue. Anytime a needle moves that fast, it needs to be cooled to avoid any thermal injury. So we do that between the needle and the skin. We have a sheath as well as a subcutaneous tissue. That sheath does two things. It protects the surrounding tissue and also directs the irrigated saline right to the needle. And then both the tissue that's debrided and cut as well as the saline is aspirated up through the central lumen. So longitudinal motion of ultrasonic energy, cutting the tissue at a 1 millimeter circumference right at the leading edge of that needle. I'm going to just go through some slides. Ryan and Robin, are you able to see these slides here okay? Just as a process?
Yes.
Okay, great. I'm going to just, thank you, Ryan. I'm just going to go through some Achilles and plantar fascia. So as many of you know, the patient will present obviously clinically with a chronic condition. They'll present clinically with point tenderness. And ultrasound has a great utility that anything that's superficial shows up very well, any of that pathological tissue, because you're essentially skin, tendon, bone. And in the Achilles, this is a great description of somebody who's got insertional tendinosis. So typically, when you're doing the procedure, not necessarily diagnosing it, but when you're doing the procedure, they're put in a prone position. The orange highlight there on the heel remarks there where the placement of the ultrasound transducer is. On the top right, you can see in a very hyperechoic, very bright structure, the calcaneus, and then healthy, organized fibers of the Achilles tendon inserting into the calcaneus. The bottom right shows degenerated tissue. Degenerated tissue will present as a dark spot or a hypoechoic area, or it can often present as a thickened area, also hypoechoic, and that's consistent with where, in this case, the patient is point tender. To do the procedure, the Tenex procedure, again, most of these are done either under local anesthesia or a little twilight sedation. They're placed in a prone position with the blue marker will identify where they're maximally tender. We have sterile ultrasound gel and a probe cover. We'll numb the skin up. We'll use a little 1% lidocaine that will not only numb the skin wheel, but then we'll go and numb the tendon. With an 11 blade, we're not making an incision. We're just making a stab puncture that facilitates the entry of our instrument. The instrument is delivered under ultrasound guidance. And I'll let this slide play a little bit. In this case, on the right side, you see the needle under ultrasound imaging, and the needle's going back and forth, working to cut and remove and debride that, in this case, that mid-substance Achilles tendon. And then over a period of time, you'll see that area becoming less thickened or hypoechoic, and it's replaced with something that looks more punctate or isoechoic. And as our physicians will remark, oftentimes you'll feel a difference in resistance because you've created a cavity, you've removed tissue. The same, again, when you're done, and we'll talk about post-treatment care, we have a steri-strip and Tegaderm that's placed, and then typically for foot and ankle, we recommend that they're put in a walking booth for a period of time. And I know both Dr. Anderson and Mendeszoon will speak to that. On the plantar fascia, as many of the attendees know, it's on a medial aspect of the heel. On the top right, you can see the contour of the calcaneus and healthy plantar fascia coming in, inserting in to the medial tubercle there of the calcaneus. You can see on the bottom, patient is point tender right in this area. You won't go having to sniff or find where there's damaged tissue. Their maximum tenderness will give you the guidance of where to put the ultrasound transducer. And there you see degenerated tissue, thickened plantar fascia tissue that presents as a hypoechoic region. This, I think, shows up on the next slide, which is a dynamic ultrasound. Again, the toes and distal are to the right. You can see the calcaneus in a very bright hyperechoic area, and then juxtaposed right above it underneath the heel pad, you see that hypoechoic area that's consistent, again, with damaged tissue and point tenderness. So the approach we take for the plantar fascia is we recommend that you don't insert the instrument on a plantar approach, but really come medially. And that's what this slide tries to illustrate. On the long axis view, as you can see by the ultrasound on the top left, that is consistent with the ultrasound on the top right, which shows a hypoechoic area kind of right as it inserts into the calcaneus. As you move the transducer cross-section to the plantar or orthogonal, you'll pick up damaged tissue, and you see on the bottom right, and I'll use my cursor here to identify, my arrows identifying the ridge of the calcaneus here, and then in this hypoechoic area, about 9 to 12 o'clock, that's where you have damaged tendon tissue. That's more on the medial aspect. And then kind of from 12 to 3, you can see healthy plantar fascia tissue. It's more punctate, it's isoechoic, and these are the collagen fibers kind of coming at you through the screen and through the lens. The approach, again, is very similar to the Achilles. X will mark where they're maximally tender. We will numb the skin on a medial approach, both the skin wheel, and then go into the plantar fascia tissue. We'll use an 11 blade to facilitate the access and the delivery of our instrument. One of the approaches we use here is if we maintain a long axis of the transducer, you can never really approach or appreciate rather, whether the needle is approaching its leading edge, the middle of the needle, or the hub. So we recommend the physicians to move their transducer crosswise so they're always seeing the length of that needle as it comes on the medial aspect into the damaged tendon, the damaged plantar fascia rather, on the medial aspect. And here's what that looks like in an ultrasound real time. So medial is to the right of the screen. You can see this hypoechoic area here from kind of 12 to 3, and this is a loop that'll play a few times. But in this area here is where you have that damaged tissue, and in this case, the physician's trying to cut and remove as much of that hypoechoic area. From 9 to 12, on the more lateral aspect there, that's healthy tissue. You can see it organized collagen fibers coming at you through the cross-section of the screen, and that's an area that you'd want to avoid. When they're done again with the plantar fascia, we have a steri-strip and Tegaderm, and then very similar to the Achilles, we'll put them in a walking boot per our recommendations. And this is kind of captured here. All of our kits are included in all our kits rather is a patient instruction postcard. And here for the foot and ankle and Achilles, what we recommend, and certainly we'd like to hear what Dr. Anderson and Mendeszoon provide instructions for their patients, but we recommend resting the foot and ankle for the day of the procedure and certainly wearing a walking boot for up to 2 weeks. They can begin some light exercises, eccentric exercises on about the 3rd day. And then when they come in to see the physician at about 6 weeks, if they're asymptomatic, they're kind of allowed to go back to moderate activity or activity is tolerated. Typically, we recommend wearing the boots for a minimum of 2 weeks. And if they're seeing some improvement in their pain and their quality of life, they can certainly discard the boot after that time. I'm just going to give a snapshot of some of our clinical studies, and then we'll turn it over to Dr. Anderson and Mendeszoon. But one of the things I wanted to share with the attendees of the webinar is we have a number of publications. These are peer-reviewed. These are prospective studies. We've had independent physicians not supported by the company do studies on the elbow all the way down to the foot and ankle. And one of the things I wanted to share with you is that we see roughly about that 85–90% success rate in terms of efficacy. It appears to be a very safe procedure. And the way we frame it is certainly those patients that would not respond favorably to the Tenex procedure, we don't burn any bridges, if you will, that would allow them to be a candidate for an open procedure, because there isn't any untoward structural damage that's done by the Tenex procedure. So certainly, if needed, they can undergo an open approach. I'm just going to give you a snapshot of some of our studies. This is a paper that was published earlier this year. Dr. Patel is a foot and ankle surgeon out of Ortho Indy. He looked at a prospective study on plantar fascia patients, 12 of them. They've been symptomatic for about 6 months. They had failed conservative treatments, including orthotics and PT. And 4 of the 12 had failed an open or endoscopic fasciotomy. We treated them one time with Tenex, and we followed them up for 12 months. At that intervals, we saw that about 92% of the patients were pain-free at 3 months and then sustained at 12 months. One of the things I will say as a company, we're always interested in long-term data. I think many of the people listening would appreciate with tendinoses or plantar fascioses, there is a large placebo effect. Lots of things work in the first month, and there's a risk of a tachyphylactic response where those patients kind of rebound. We wanted to really be honest with ourselves and see how they did 1 year out. That's what you see in this study. And then Dr. Patel also looked at a quality of life that he assessed at both 6 months all the way out to 12 months, and he saw improvement at 6 months and again sustained at 12 months. There was a larger cohort of plantar fasciitis. This paper has been submitted for publication. It was presented in a public forum earlier this year. This came out of Lincoln, Nebraska. Dr. Rosden looked at 100 patients, again, symptomatic for 6 months with plantar fasciitis. Similar kind of profile of failing conservative treatment. One-time treatment of Tenex, nothing else. 12-month follow-up, didn't report any complications. Dr. Rosden was interested in looking at pain as well as a disability index measured by the FATI score, and he followed this assessment at 2 weeks all the way out to 12 months. He found significant improvement in the pain and disability at 2 weeks, sustained at 12 months. 91% of the patients were pain-free at that 6-month interval, and again, sustained at 12 months. The next paper I'll just highlight for you, this was recently accepted in the journal of the APMA. Dr. Ellis is a podiatric surgeon out of Phoenix. He looked at 26 patients. They were symptomatic for 18 months, single treatment. They actually measured the amount of energy that it took to perform the treatment. It took about 2.5 minutes. He followed these patients all their way out to 16 months. 88% of these Achilles tendinosis patients were pain-free at a month and sustained at 16 months, and then about the same number of patients would recommend having the procedure done again. Dr. Patel recently had a paper. He's had a large experience with plantar fibroma. This is just kind of an ancillary, I think, an experience. We obviously don't have a robustness here of data, but one that certainly was done in a prospective measure, and one was done in a controlled measure with each patient serving as their own control. They had 15 months of previous symptoms. Again, failed their conservative treatments. Interestingly, Dr. Patel followed these patients up for 2.5 years, and he found that all these patients had resolution of symptoms a little over 60 days, improvement in the quality of life score, and then no recurrence at least up to 2.5 years. So an interesting observation, interesting phenomena, and since it's public domain and published literature, I certainly wanted to present this to the group as well. One of the things we look at as a company frequently is what's our community experience and how does this become similar or how does it deviate from the published literature. And we routinely bring a number of physicians together. We did this a couple months back, and we looked at the kind of cutting time of the energy time required to effectively treat the body parts. We looked at elbow all the way up to plantar fascia, and there you can see it takes a little bit longer to effectively treat the plantar fascia. It's a much more vigorous tissue. It has more resistance, so it takes a little bit more time to get through all of that. We looked at also clinical outcomes, and we see that most patients, about 80% of them, seem to be responsive to the therapy in about 2 to 3 months. There's the lucky few, so 5% of those to get better within a month. And then we don't consider this a failed treatment until you haven't been fully responded to at 6 months. And at least from our experience, I'd like to hear from Dr. Anderson as well as Mendeszoon. Can you predict which patients are going to do better versus not be responsive? That's one of the things that we as a company are trying to get smarter about. And then as a corollary to that, we're also trying to get smarter about what's the optimum post-treatment regimen. So those are things certainly that we're trying to sleuth out as we speak. So with that, I'm going to stop and kind of bring in both Dr. Mendeszoon and Anderson. So as I said in my preamble, Dr. Anderson is a podiatric surgeon and living in probably one of the best city names in the country, Bountiful, Utah. He's with the foot and ankle specialist. And then Dr. Mark Mendeszoon is a podiatric surgeon. He's in a multidisciplinary group physician orthopedic specialist practicing out of Chardon, a little outside of Cleveland, Ohio. So I want to tempt fate here and see if the webinar gods are on my side. Can you hear me okay, Ryan?
I can, thanks.
Great. Mark, are you with us?
I think I am.
All right. It's a blessed day, right? The small blessings when webinars work. So thank you both for joining on the webinar. Ryan, I'm going to start with you, but I'll pose the question for both of you. If you can share with the group a little bit about your practice, as well as what first got you interested in Tenex when you were presented with the technology. So Ryan, let me start with you.
Thanks, Juggy. I have to say to those listening, too, it's a little bit nerve-wracking following somebody who speaks so articulately, if that's a word. But I'll try to do my best, Juggy, to make you proud.
All right.
Yeah, so I've been in practice for about 12 years, and we were at a point where we have always seen a lot of plantar fasciitis patients. We were doing a lot of dry needling in our clinic under ultrasound guidance when the rep showed up with this new device, this Tenex device, and a piece of steak, and he wanted to do a little demonstration with us. So we were able to on that first day that we heard about Tenex, get our hands on the device and use it on I think it was a New York steak, but we were able to kind of feel how the Tenex worked, and we thought it was pretty cool technology, and at that point in time, we were happy with the dry needling, but at the best, we were probably getting 65 to 70% success rate as far as people getting better. And so ever since we grabbed onto the Tenex and kind of incorporated it into our clinic, we've had fantastic results. We market for it, and it's been a great. I honestly, I can't imagine practicing and treating particularly chronic plantar fasciitis without having this in our armamentarium.
Awesome, perfect. Thank you, Ryan. Mark, a little bit about yourself, if you can introduce the group, and then your initial experience of why you took the appointment with Tenex.
Absolutely. I've been in practice in Chardon for about 21 years and have a heavy sports medicine practice. We cover about 10 high schools in our community. I do a lot of work with track and field, working with a lot of athletes ranging from little kids to professional Olympians. And, I think one of the big things we have is just dealing with those chronic plantar fasciitis conditions, fasciosis conditions that have failed conservative measures. I've tried different elements with the, with topaz and things like that, which I didn't get good results, and it was kind of barbaric. And so I'm going to up Ryan on one because I didn't have a rep. I had Juggy come to my office on a snowy February day, and I think he had a prime rib or something with us. And, he showed us, and we had a patient that we started doing it on, and the results were pretty impressive. And actually, my first case was an Achilles tendon with a gentleman who ran Boston Marathon. And he needed a reconstruction like an FHL tendon transfer, and we tried this on him, and I was very happy with the results, and so was he, and we started using it on different body parts of the lower extremity, and I've been very happy with it. And I utilize it as a step to avoid reconstructive surgery. As much as we like to cut people open, if I can get them back to the field or pain-free without having the complications of major open surgery, it's definitely a practice builder, and it goes a long way.
Awesome. Mark, thank you for that. Let me stay with you, Mark. You talked about that February day. You've been doing it for a while. Share with the group about how many patients you've treated at various anatomic locations, and if you could, add in your clinical outcomes to the best of your assessment, and then any complications that you've come across.
Absolutely. I think I'm about 225 to 250 cases. I use them on, obviously, the plantar fascia. I really am a big proponent of the mid-substance Achilles tendinosis, and I've also been using them on posterior tibial tendinosis and perineal tendons, and I've done a couple of plantar fibromas. I would say that definitely the mid-substance Achilles tendinosis cases are about 90 to 95% successful, meaning I do not have to take them for a reconstruction procedure. The plantar fascia cases, in my experience, are about 80, 85%. And I've been really happy with the perineal tendons, especially at the insertional and around as they course through the the lateral malleolus. I've been happy with those, as well as the PT tendon. Now, I know with PT tendon, with the flat foot deformity, that these people may eventually need a reconstruction, and they're aware of that. And I use this as an alternative and see how long we can get. And some of the people we've been doing PT tendon procedures have been doing well thus far for about 2 years. How long it will continue to last, we'll see. We have them in appropriate shoes and orthosis and still doing their range of motion and working on that Achilles flexibility. And then lastly is the insertional calcific tendinosis procedures. Those are a little bit more difficult, I think, especially with the size and magnitude of the spur and the calcium deposits. I think that's about 70 to 75% in my hands of where I may not have to go in and do a posterior procedure on that. So that's kind of the experience and results I've been seeing in the last 2.5, 3 years. As far as complications, really none. One lady had a post-op wound, but she was working in the horses and working in barns and didn't follow instructions. And then I had one tip that broke in a patient that I had to retrieve. So that's really the only 2 complications I've had of the 200, 250 cases.
Good. Thank you for that. I'll ask you a question on the patients, and I think it would be good to get Ryan's input as well. For the ones that have been successful with this treatment, have you had a sense, now that you've got a large body, do you have a sense, Mark, of who you know will have a good outcome versus ones that you kind of hedge your bets that they may not be responsive to this?
Absolutely. I think as we do our patient selection, you really have to have an overlying view of the patient. I think patients that have the chronic pain syndrome, the fibromyalgias, I'm a little hesitant to going forward and doing a procedure. I mean, obviously somebody who's athletic, who wants to get back on the playing field, wants to get back to training, somebody who wants to avoid being on medication. So I think they have to have a positive outlook. And I think the risk that you discuss with them and the patient selection is very important, as with any other surgery. But I would say the two biggest components that I really try to hedge away from any patient is definitely the patients with fibromyalgia, which I don't think you're going to get good results, and then patients with chronic pain. I'm very leery on approaching this with them.
Understood. Good. And then, not that I gloss over it, but if you can explain to the group with your two complications, the patient that had the presence of the wound and then the tip, what did you do as additional treatments to address that?
Right. The one lady who had the plantar fascia procedure had a cellulitis, and the wound was a little moist, and she had a localized cellulitis, and it was raging above the ankle. So basically, I brought her into the hospital for about 2 days of IV antibiotics and dressing changes, and read her the riot act to stay out of the barn. And then the gentleman who the tip broke into his Achilles tendon, he did very well, but with the ultrasound, I was able to see the tip. So one thing I will always do now is always inspect the tip to make sure the inner sleeve is still intact. So I was able to retrieve that post-surgically on the same day, and that, he did relatively well without any complications. So he's actually back running 60 miles a week.
Good. Thank you for that. Ryan, let me shift over to you, the same kind of questions, your patient experience, anatomic sites, and then the complications in your hands.
Sure. So to Mark's point, we see a lot of those chronic plantar fasciitis type patients. We're kind of in this weird run right now where I'd say probably 6 or 7 out of 10 new patients that come in with fasciitis is a woman between 35 to 45 years old. She's got 3 or 4 kids, and she's running and trying to lose some weight and get in shape. And so we see a lot of just frustrated patients like this that have had it for 6 months or longer. They've maybe seen one other physician. They've spent money on over-the-counter products. They've even probably had a cortisone shot, some physical therapy with no relief. And so they come in usually pretty motivated to have something more definitive done. And the Tenex is obviously a very something that they grasp onto quickly because of the non-invasiveness of it. So typically, as far as selecting the right patients, obviously we like to rule out and make sure that they don't have any type of nerve entrapments or issues like that going on. Obviously, I see some patients that have extremely tight plantar fasciitis or plantar fascia, kind of the cavus type foot, and in my experience, they have not usually done well with Tenex. But for the most part, I have not been able to predict. We've had such a great success rate with plantar fasciitis that I'll see some that that the fascia measures, just almost a centimeter in thickness. And you'll see another one that's barely a half of a centimeter in thickness, and it's just really hard to predict who's going to do well and who's not, just because the percentage has been so high. I've been amazed at some that we felt like we had to be more aggressive on, and that we kind of prepared them preoperatively for a long healing period, that have just done phenomenal in the early postoperative phase. And so we've been really happy with that.
And on that point, we see this with our colleagues in the upper extremity world, that there seems to be a loose, not necessarily tight, a loose correlation between cortisone injections and certainly outcomes. And you see this in jumper's knee and tennis elbow. Do you see any of that in the plantar fascia patients that you treat, Ryan, with multiple cortisone shots? Or do you see people not giving cortisone shots even for the plantar fascia now?
I would say we still see, at least here in Utah, people have, usually by the time we see somebody, they've had at least one cortisone shot, unless they're a new patient and it's a new onset of plantar fasciitis. But as far as the prediction, some people, obviously we're not seeing the people that have maybe gotten better or their symptoms have been alleviated with conservative care. So we see a lot of people patients that will try through a conservative care, including maybe a cortisone injection, night splint, maybe even a boot, and they haven't done well. But with a Tenex, for whatever reason, we're able to to get them some symptomatic relief fairly quickly.
Yeah.
Did that answer your question, Juggy?
It did. It did. Yes, thank you very, very much. What about complications in your hands, Ryan?
For us, so I've had 2 patients. I've done, by the way, probably a little over 300 cases. Probably 90% of them have been plantar fascia cases, and we've had 2 patients. One in particular was a male nurse that worked at our surgery center that had had a little cellulitis afterwards in the incision site. He went back. He was feeling so good, he went back and did a shift 5 days later for a 10-hour shift, and ended up with some cellulitis in his heel. Both of those have resolved pretty quickly with some oral antibiotics. We've had one patient that was walking upstairs a week later and felt a pop and a strain, and came to the office. We took an ultrasound. A small amount of medial fibers had separated. We put her into a boot, and she was within a week doing fantastic. So that's why I am a big believer in putting them into a cam walker boot afterwards, because typically the patients are feeling so well that they disregard a lot of the post-op instructions to take it easy. They're usually trying to do activities and be active.
You know, you raise a good point. You know, as kind of channeling my inner scientist, physiologically, what you think about you're doing, you're removing that degenerated tissue that is providing a lot of the neurokines and substance P, which our brain anticipates and predicts as pain. When you remove that, the risk you run is that you eliminate the pain reflex, which is a very good reflex for us. So on that, what do both of you do? And Mark, I'll put it to you. What are some of the post-treatment managements that you put both for Achilles, whether it's mid-substance, insertional, and plantar fascia? What do you provide? And then I'll have you think about it, Ryan, because you'll be up next.
Thanks.
That's a good question that Ryan brought up. Post-operatively, you know, when I talk to the patients, I tell them, you've been dealing with this for so long, and I'm very protective with a walking boot. And minimum, at best, for plantar fascia is 2 weeks, but I tell them expect anywhere from 2 to 4 weeks with the walking boot. I normally have them take the dressing off in about 2 to 3 days after surgery, and they can take a quick shower and just do a little antibiotic ointment on the wound site and start gentle range of motion and icing. You know, ambulate to what they can tolerate. But with plantar fascia, it's anywhere from 2 to 4 weeks, and I usually prepare them. You will be in the walking boot for 4 weeks. Without a doubt, the Achilles tendon, I just don't want somebody to rupture the Achilles postoperatively, whether they slip or fall. And so I keep them in a high-tide boot for approximately 4 weeks. I do let them maybe start getting into a pool around 2 weeks, some gentle cycling in about 2 weeks, non-weight bearing. And I have them start doing some, you know, massage therapy and icing. At about 4 weeks postoperatively, I'll start between 4 weeks and 6 weeks, I'll start some formal physical therapy just to get them going and feeling confident that they're not doing too much, and we can progress them slowly. But all in all, I tell people, it can take anywhere from 6 to 8 weeks before you feel decent and getting around. We can ease you back to some type of activity. And around 12 weeks, I would expect that the majority of people are back full-fledged. So I am protected with the boot. I do like early range of motion, icing, scar therapy, and then physical therapy about 6 weeks after.
Good. Very helpful. Ryan, how about yourself? What do you prescribe?
Yeah, very similar to Mark. I'm a big believer in the cam walker boot. We always have them wear that immediately afterwards, weight bearing for 2 weeks. We'll have them keep the dressing wound clean and dry and keep the dressing intact for 3 to 4 days. So usually, you know, I'll operate on Thursday and have them keep it clean and dry till Monday. And then after the 2 weeks, if they're doing well, usually we've seen them at least once in the office for a post-op. After the first 5 days, I will have them start to use the night splint consistently in the evening time. And if they haven't been given one, we'll dispense it to them at that point in time to start using. At about 2 weeks, we'll put them into a soft, supportive pair of shoes, like, you know, a pair of running shoes. I find it's really hard, especially with the runners, to keep them slowed down. Even if we talk about time frame of healing, usually when they're feeling good at 10 to 14 days, they almost always cheat and go for a run and do stuff. So you've got to really make sure that you keep the expectations where they should be and let them know what you expect as far as the tissue is still healing for up to 4 weeks.
So you mentioned at the outset the kind of patients that you look at, and they're obviously very active. How do you manage those patients that want to get back into running? Because certainly for plantar fascia and Achilles, you have a subculture of runners that are almost addictive to their running regimen. How do you have that conversation, and what do you do to kind of optimize that?
I'm usually okay with them to begin stationary bike and even swimming at the 2-week point, and then most of them by 4 to 6 weeks, depending on the patient, their activity, where they are as a runner, and their body frame size. To be honest with you, I'll kind of let them get back to running at that point in time. But usually, if we explain to them really well, hey, we're going to get you back this quickly, but if you push it too soon, then you're possibly going to miss another 4 to 6 weeks of training. Usually, they're pretty good about following the instructions before they get back into it. So we just try to give them some type of other exercise that they can perform to keep them balanced.
Good, thank you. Let me stay with you, Ryan. What kind of surprised you the most? You've been doing, as you said, 300 procedures, and you're obviously getting facile with this. But as you started doing it and grew your practice, what surprised you the most about the product and the technique?
Yeah, well, I think I mentioned this before, Juggy, but for me, the biggest thing, and we've been lately filming testimonials from patients because of this, because you'll see a patient in your office for the pre-op visit that is just at their wit's end. I mean, fasciitis may not on the scale of medical things be one of the worst conditions you can have, but it can be very painful, and people are borderline depressed because the pain keeps them from doing things they want to do, but they're still able to get around, so that they don't see it as a serious medical issue. So from seeing them at the pre-op visit where they're just frustrated and almost depressed, to seeing them immediately post-op where their pain levels are dramatically decreased. I mean, and they are just very excited. That's been the thing that has stood out to me. And granted, we don't see every patient that way immediately. You'll definitely see a percentage that come in that are bruised and tender, and they're just going to follow the normal healing route. But for whatever reason, we see a high percentage that come in that are just virtually almost pain-free. I mean, obviously they've been up in a boot and off their feet, but they're used to having pain at night, every night after being on their heel. And so to me, that's been really cool to see.
Good, thank you for that. Mark, how about yourself?
Yeah, I would say that definitely it helps with plantar fascia. We know all the treatments and the panacea treatments that are out there for trying to get it better. I think this has definitely added another layer to treat patients and to avoid cutting them open. I would say for me, doing an open procedure in the last 20 years, if I've done 20 to 25 open procedures for plantar fasciitis, that's a lot. So this really has helped diminish that number. But what I'm really excited about is, especially with the Achilles tendon, the PT tendon, peroneal tendons, that it diminishes my ability to open them up. As much as we like to cut people open and do surgery, if I can get them back quicker, I think it builds a practice, and it really, can avoid the headaches and complications if someone has a bad Achilles tendon and you have to do a reconstruction, whether it's a gastric turn down or whether it's a FHL transfer. Those are brutal surgeries, and it's a long recovery. And I think one of the best things that people like is that they don't have to be immobilized in a cast, and that really is helpful. And so it really has changed my spectrum of practice, and it has really grown my practice, especially with the sports medicine community. So I've been really happy in that aspect. And as much as I like to do surgery, not doing surgery sometimes is the best answer.
Yeah, well said. Well, I want to be sensitive to everyone's time. There's a number of questions that have been chimed in that I'm going to just kind of read through. And Mark, I'll stick with you. One of the questions that came in is, we talked about, at least for the Achilles, we talked about the plantar, that there's that point tenderness, that resolution of symptoms. One of the attendees said that he's done about 6 of these, and 2 months in, that point tenderness is still there. Do you see that in your experience, that even 2 months into the treatment, post-treatment rather, the patient is still experiencing that post-treatment point tenderness at palpation? And what kind of guidance would you give based on that experience? So, Mark, any feedback from you?
Absolutely. It's not unusual to have tenderness, at least even for any incision you do, for up to 3 months. I'm very selective and try to be precise. I try to get right there on the plantar medial incision or the skin site, so I'm not plantar and I'm not too medial. You have to be careful that you're not too proximally to hit the medial calcaneal branch of the nerves. But post-operatively, I'm a big believer in scar therapy and manipulation. And, that's where I think a physical therapist can come in and help them, guide them. If they're really struggling after about 4 to 6 weeks, then physical therapy for some ultrasound, scar therapy, and even a home TENS unit can help desensitize that region. And then lastly, some of the topical compound medications can help desensitize that region as well. But I think really just getting your fingers in there and breaking up the scar tissue can hopefully make them feel better.
Good, thank you. Ryan, any feedback about patients that you see that are 2 months post-procedure and still have experience of that point tenderness at the point of insertion?
Sure, yeah, I loved what Mark said. I agree with everything that he just said. I also like to have them freeze a water bottle and just roll it forcefully and massage that area for 20 minutes each night. I found that really helps. Also, I find that some patients are getting back into their shoes with a stiff, rigid orthotic too soon, and sometimes that the rigid orthotic can aggravate that incision while it's still healing.
Good point. Another question that came out, this is more of a technique question. When you're taking the medial approach to address plantar fasciosis, how do you assure the avoidance of any of the medial nerve branches? So, Ryan, we'll start with you.
I just like Mark mentioned, I like to keep it proximal enough. Usually you can palpate and mark out preoperatively where that nerve runs in that little groove on the medial side of the calcaneus. But to be honest with you, I just don't see a lot of sensitivity issues when we're just kind of focusing on that plantar medial tubercle area in the plantar fascia. But obviously, I think if you stray and go a little too distal and get a little too aggressive that way, then I think you can definitely irritate some nerve branches.
Mark, what's been your experience?
Yeah, I'd have to concur with Ryan. And, we never know people's anatomical variety. And sometimes people may have that Baxter's nerve or a branch of nerve that's a little different than typically. So I definitely mark out my medial malleolus, and I try to course where the tarsal tunnel is and try to mark out the medial calcaneal branch. And one of the issues is that when you get in there, you have to definitely, this is the importance of using and having proficiency with the ultrasound. I think it's very important to guide that tip and seeing the diseased portion of the tissue and getting into that area and then getting out. I've seen some of my residents or fellows that would start and they would just kind of maybe haphazardly just take that TX1 handpiece and just go back and forth. One of the things that you feel is that as you separate the scar tissue from the healthy tissue, it's kind of like taking a hot knife through butter. It'll start gliding. And once you feel that, that's a tactile sensation that you know that you've done your job. But also it's so important to have the ultrasound guidance so that you're in the right area.
On that point, one of the other questions is, regarding around ultrasound guidance, what was your familiarity with ultrasound before you started Tenex, and how important is it? And I think you addressed the second part of that, but again, the first part of that question, what was your familiarity with ultrasound before you started using Tenex?
Well, I'll back into that. Tenex has made me definitely a much better ultrasound technician. But prior to the procedure, our practice did go to a course and train with it. So we were doing ultrasounds for about a couple of years prior. So I felt very confident and capable of using ultrasound. And, I use it pretty much for every venue for when people come in if I have to do anything invasively.
How about you, Ryan? Did you learn ultrasound through a course? How did you get familiar with ultrasound? Tell us your story.
Yeah, I had a unit my second year in practice. I went to a conference and took a course, and we got one and just slowly became more familiar using it. So by the time we had the chance to adopt Tenex into our practice, like I mentioned previously, we'd been doing dry needling in the office under ultrasound guidance. It was just a natural step for us to take the Tenex and start using it with the ultrasound. I will say also, Juggy, just the more you use the ultrasound and see different heels and different fascia, different Achilles tendons, you kind of just, when you see a certain tendon or a certain fascia, you start to, from having seen so many, you kind of know what state they're in and what the tissue's like and how aggressive you're going to have to be. And like Mark mentioned, you definitely kind of start to get a tactile feel where you can tell when you've done your job, and you can feel the different consistencies and the different layers of scar tissue in certain feet. And so it's definitely an ongoing educational process.
Okay, very helpful. On that point, one of the last questions I have for both of you, from the time that you had the T-bone to the time that you felt really comfortable with your facility of doing, whether it's a plantar fascia Achilles, what was your learning curve? We'll start with you, Ryan. How many procedures did you have to do before you felt that you had a good rhythm to the technique?
The technique, it's hard for me to answer that question. I can tell you that after about 10 minutes using the wand on the stake, I got a feel for how it feels going through tissue. We have residents that rotate through our clinic here that assist us, and they do a 2-month rotation. And I would say by the time they leave here after 2 months, they're all very proficient. By the time they're in their last couple of weeks with me, I'm letting them do the majority of the Tenex procedure while I'm sitting right there next to them. And it's just they grasp onto it really quickly, and most of them that I know are out in practice doing Tenex right now. So I would say maybe after a dozen procedures, even before that, you can feel pretty comfortable with it.
Good, that's helpful. Mark, what's been your experience, whether it's for yourself or the folks that you train?
Yeah, I agree with Ryan. I believe that, after maybe 5 to 10 procedures, you get comfortable with the instrumentation, you get comfortable with the ultrasound. You start getting an understanding of how the diseased tissue will feel and how it looks like underneath the ultrasound. And same thing, once we get our residents, I guide them through that. But after 2 or 3 of the treatments, they're pretty proficient. And we'll walk them through some of the other, difficult cases. But all in all, I think if you have about 5 to 10 cases under your belt per body part, then I think that you'll do pretty well and feel pretty comfortable. So it's not a huge learning curve, and it's not a difficult learning curve.
I agree.
Good,
yeah.
Good, thank you. Well, I'm always very sensitive to the time. I've got, we've been talking for about 50 minutes. Robin, if you're still on the line, what I'd like to do is open up the mics to all the participants, and it's going to get a little choppy and noisy, so everyone just bear with us. And we'll open up the mics to see if anyone wants to put a question into either Dr. Mendeszoon or Dr. Anderson. I'll remind everybody that as Robin is opening up the mics, if you're in a noisy spot, your mics are going to be live. So if you don't want to ask a question, if you want to mute your phone so we don't pick up any of the background here. So, Robin, you just give me the hi sign when all the mics are live.
Okay, Jackie, I'll let you know. Thank you.
Sure, yeah. No questions? No, I don't think I hear anything.
I have a question.
Yeah, please.
So my name is Greg Catalano. I'm speaking from Concord, Massachusetts.
Yeah, we can hear you loud and clear. Please go ahead.
Okay,
Thank you.
so my question is, I've started doing the procedure in July. I've done about a half dozen. It seems like the focal area of pain on the plantar fascia, plantar medial aspect, I'm getting nice results. But it also seems like I'm uncovering other areas of pain, maybe a little bit of lower tarsal tunnel or some plantar fascial pain that patients weren't as aware of that is more distal, maybe compensation type pain. And I was wondering if anyone else had that same experience and how long it takes for everything to settle down before people are feeling pretty comfortable.
That was a very clear question. I won't repeat that question. Thank you again for that question. Well phrased. Mark, maybe I'll let you handle that one first.
Yeah, especially with the plantar fascia, it's really important to get your landmark as far as the medial tubercle, and even if you draw that out and your medial malleolus and kind of predict where your nerves are going. But it's not unusual that whatever procedure, whether you do an endoscopy or you do a Tenex, you have to be careful and realize that these people are going to compensate, especially if they're up on their feet a little bit earlier. So I would say if you're not utilizing physical therapy and manipulation and scar therapy on their heel, that will resolve with time. If it starts to become a pattern, then you may want to back off on how much time you're using and exactly, what the angle of the tip that you're using. Sometimes when people go straight across, they may be hitting some of those lateral bands. And even with open plantar fasciotomies, we want to try to avoid that lateral third band. So that's some recommendations I would have is keep them icing, stretching, protect them with maybe a soft insert, as Ryan said earlier, and, physical therapy I think would be very helpful.
Good. Ryan, anything to add to that?
Yeah, I definitely, if you're not using a night splint post-operatively, I love to do that. I would also say that we see a lot of patients that when we treat the large amount of pain that it's at the plantar medial aspect, and we relieve that, and right after the surgery they're feeling great, a lot of people, it will uncover some peroneal tendinitis or some lateral fasciitis because they've been walking on the outside of their foot and supinating their foot for months to compensate for that pain. And so we'll usually, I'll try to address that before the surgery if we know they have those symptoms, and if they're experiencing that and complaining about that immediately post-operatively. Just like Mark mentioned, I think physical therapy, stretching, even wearing the boot for a longer period of time, a lot of those things will take care of themselves.
Any other questions from the audience? I'll finish off by thanking both Mark and Ryan for their time. I thank all the attendees. Before we dispatch and let you go, Mark and Ryan, you guys have been kind of doing the product, using the product for 2 years, and you've gone through the evolution of probably initially being skeptical of anything new and then using it. And like anything, you have your ebbs and flows in terms of outcomes. As you've been now 200 plus and 300 plus procedures, what would be your guidance to those folks that are listening that are interested in adopting it? What are some of the practical as well as clinical guidances that you would give them? So, Ryan, I'll start with you as kind of as parting thoughts.
Thanks. Yeah, I would say making sure that you feel very comfortable with an ultrasound, and you can do that by looking at a lot of heels in clinic, by practicing on staff members, but being comfortable with the ultrasound is going to take maybe take away any doubts that you might have about taking on this technology. As far as treating patients, I think I go through runs. I'll have a morning where I'll have 2 or 3 post-op patients that are immediately post-op that are hurting and they're in pain. But and you just have to realize that you're going to go through runs like that where maybe you don't get that immediate gratification where the patients are doing fantastic in the first couple of weeks. But by far and large, I can't imagine for those that want to grow their practice and really want to focus on sports medicine and maybe even more specifically on plantar fasciitis or Achilles tendinitis, I really can't imagine practicing without having something like Tenex to go to. Just like Mark mentioned, you're able to avoid a lot of open surgeries, and not only for athletes, but in this day and age, most patients, people are busy. People don't have time to be off their feet and be on crutches, and so they love the idea of a procedure like this that allows them to get back to activity fairly quickly. So I would just say learn as much as you can about this technology and get comfortable with ultrasound, and it will be a great benefit to your practice.
Great. Ryan, thank you for those comments. Mark, you're the last one. You can finish it up strong. So any guidance to the group there, both clinically as well as from practice development?
I like being the ankle leg, so give me a bit of time. As I mentioned earlier, I think you have to set realistic goals and realistic outcomes for your patient. I think you have to be very important and very selective on who you take initially. Don't let this be the end-all, be-all, say, hey, it's going to cure everything. I think if you set unrealistic goals and you say, hey, this is going to fix you, no ifs, ands, or buts, and you're going to be better and you're going to be up on your feet in 2 weeks, I would ask you to err initially on the side of caution. Keep them in the boot for 2 to 4 weeks. Tell them they need physical therapy. Tell them they'll need the night sprint. They need to do icing. They need to be patient. And I think if you set up those goals, and as you do more cases, be selective on who you start with, practice your ultrasound, whether you're doing heel injections or other type of injections in the office, use the ultrasound, and just start, getting a hand. I have a handpiece in my office that I show the patients. And I say, this is what it looks like. This is how we're going to enter your foot or your leg. This is what we expect afterwards. And I think you're in the proper communications with your patients, set realistic goals, maybe err on the side of saying it's going to take the full 3 months, because if you give them that and they're great in 6 weeks, you become a hero. But if you tell them in 4 weeks you're going to go run the marathon And and they're not able to do that, they're going to have disappointment. And there's also that, mind over matter. So if you can get their mind right, I think it'll help them heal.
That's great, Mark. Thank you for those very honest remarks. So both of you, exceptional surgeons and certainly exceptional presenters. So thank you for your time. We'll close off the webinar. I want to thank everyone for listening in, and have a very nice rest of the evening. Thank you again. Bye-bye.
Thank you, Dougie.